If we could
Maybe.
if we could pull up Dr. Page's slides. There we go.
There you go. Missed my disclosures, though. Let's see if I can go back. No. Well, I guess you guys don't get my disclosures. There you go. Let's be honest, these past few years for breast cancer immune therapy have been a whirlwind. There's been a lot of great successes. We've got FDA registrations. We've had failures as well. This is a good visual depiction of that. It's a table of the phase 3 neoadjuvant clinical trials where we have a preliminary signal. And as you can see on the right here, using PathCR as a surrogate for benefit, the first 2 trials were positive, with benefits with the addition of either atezolizumab or pembrolizumab, and then the second 2 trials were negative. So what's going on here? I think if the answer to that question was easy, we would already know it. So let's inspect some of the factors that could contribute to response to immune therapy. This is a 2x2 grid that I put together, thinking of the different categories of potential determinants of response. As you can see, looking at the left, there's different patient-level factors that may contribute. Host-level factors such as the fitness of the immune system, the features of the tumor, the subtleties of the IO agent, which are definitely underexplored, and then look at the other treatment category. So we have so many different combinations that we've been putting together with IO agents. But that's just the beginning of the story, because when you look at the details, it's the interaction effect of all of these different factors that probably contribute the most. So that's what today's 4 posters are all about. It's about harnessing next-generation technologies to explore these potential interaction factors. So let's dive into the posters. First one is a very interesting notion of using RNA signatures, so genomic studies, as surrogate markers for histologic findings. Particularly, we're looking at a surrogate measure of tertiary lymphoid structures, which are known to be a favorable prognostic sign in breast cancer and other cancers. And this is explored by Hitam Soliman and others in the context of the I-SPY trial. Here's some background. For those that aren't aware of what tertiary lymphoid structures are, they look a lot like ectopic lymph nodes. They're found within either the tumor microenvironment or adjacent to the microenvironment. I think the authors used a very nice analogy, calling these as forward bases for immune activity. They're constellations of a variety of different types of immune cells, B cells, various sorts of T cells that form organized structures that might be the site of initiation or perpetuation of immune responses. The problem with using this biomarker in the neoadjuvant setting might be that the core biopsies that we usually obtain are quite small relative to resection tissue. So it may not be that feasible to look for these TLSs with those small specimens. So for that reason, there's interest in looking at surrogate markers of TLSs. And the authors have championed this concept with development of a 12 chemokine gene signature called the CHEK12 signature. It was first developed in colon cancer, and it correlates very tightly with the presence of TLSs. They've also looked at it in the context of early-stage breast cancer. As you can see on the right, there's a very kind of a straightforward Kaplan-Meier curve that we see all the time. It shows an improved prognosis with a high chemokine 12 signature. So the organic next step is to see if this could serve clinically as a way of directing therapy. So for that aim, the authors have borrowed from the I-SPY 12 trial, which is a very data-rich clinical trial that enrolls patients to either a control arm or revolving experimental arms. There's been many different arms, but we have 12 different therapies that we're evaluating in the context of this genomic analysis today, as you can see on the right. So this is the synopsis of the data. A lot of data to digest in one figure, but if you let your eye direct you, you see a very common pattern evolving across all these different treatments, including the control, mind you. There's an improvement in PathCR potentially based on this 12 chemokine signature, as indicated by higher mean levels in the PathCR group, and this is across the board. So diving more into the details, one aspect of I-SPY is that there's multiple subtypes of breast cancer that are being evaluated. As you can see on the left, there's triple negative cohorts, hormone receptor positive, as well as HER2 positive. So I think this is a very clever way of demonstrating a ton of data, looking at the significance levels of this chemokine 12 signature across all these different pairs of subsets of breast cancer, as well as treatments. And as you can see, the large red dots indicate statistical significance, and the largest of those dots cluster on the right, which is where the 3 immunotherapy-based experimental arms are. First one, pembrolizumab, second one, durvalumab with olaparib, and the third one was a novel agent, SD101, which is a toll-like receptor 9 agonist, which had the strongest signal with this biomarker. The authors made an important point, which is that potentially the TLR9 receptors are active in the TLSs themselves, and that may be an explanation for the improved predictive benefit. I think this is a very important gesture made by the authors to compare their data to the data of others, and that's also a virtue of the I-SPY trial. This is a very large collection of RNA specimens with many different investigators. So they looked at different genomic pathways, and they compared the efficacy for prediction. And as you can see here, the very rightmost column is the chemokine 12 signature, so most likely to be predictive of benefit across a wide variety of treatments. So the conclusions, authors conclude there's potential here for prediction. They also make an important point that perhaps the crosstalk between different types of immune cells is important, as indicated by the presence of TLSs, which include B cells and T cells. And then finally, we can obtain these data and validate it in other RNA expression data sets. My additional insights to add to that, well, I think we have to really dive into the details before claiming that this is a predictive biomarker, because in fact the control arm also was associated with this biomarker. So this may be prognostic rather than predictive, but nonetheless I think it's a very important finding. The next thing that I'd like to point out is it would be nice to actually compare this in this data set to the histologic presence versus absence of TLSs. The next poster is another RNA sequencing study to develop a prediction tool for response to IO. And this time it was in the context of the NeoTRIP study, which we'll review. To give you a background about this particular gene signature, it's derived from the classic molecular subtypes of triple-negative breast cancer by Lehman et al. In 2011. Most of you will be familiar with this classification system. It includes the basal-like triple negatives, mesenchymal, stem-like, and luminal androgen. Nested within these subtypes, there's also an immunomodulatory signature, which, using computational methods, the authors have parsed down to 27 genes. This data has already been presented recently at ESMO. They used the investigational RNA sequencing from a variety of trials, and they showed a predictive benefit in the context of the NeoTRIP study and also the durvalumab with nab-paclitaxel and AC study, which was published. The next step then is to evaluate an assay that could be readily used in the clinic, and that's what this particular data set is about. The co-authors have compared this investigational signature to a novel RT-PCR-based assay called Determa-IO, which is CLIA certified and could potentially be validated clinically. So the question is, does this RT-PCR-based assay also predict response in the context of the NeoTRIP study? To refresh your memory, this was a combination study in the neoadjuvant setting that evaluated carbo with nab-paclitaxel plus or minus atezolizumab. It's a large study, and they had the majority of the specimens for this biomarker analysis. First question is, are the two assays concordant? And the answer clearly to me is yes. The Pearson's correlation was 0.94, very tight correlation, which I think has favorable implications for doing exploratory research with RNA-seq. Also on the right gives you kind of a snapshot of the percentage of patients that would be positive for this biomarker if you were to use it as a binomial yes or high versus low variable. So 40 to 40% patients of these triple negatives were positive for the IO assay. And here's the outcome in terms of prediction. On the left, we see a continuous variable. The performance, I think, is quite convincing. In the blue line, you see as the IO score increases, the probability of path-CR also increases. This is in contrast to the arm that does not contain atezo. So the pink arm was the chemotherapy alone, and that did not show quite as convincing of a correlation. And to me, that suggests that this is bona fide prediction. On the right, you see the prognostic or the prediction benefit as a binary high versus low variable. And as you can see in the turquoise, there's a wide differential in path-CR with the atezolizumab arm with a path-CR of 45 versus 70%. Finally, we don't want to have redundant assays. Let's take a look and see if this has a tight correlation with the IHC for PD-L1. And as you can see here, there's only a modest correlation with immunohistochemistry for PD-L1. And to me, that suggests that we should explore both of these biomarkers as promising ways of selecting patients. And as you can see on the right, the left-hand column is a column of patients that were negative for PD-L1 IHC, but positive for the IO assay, with a very striking path-CR rate of 75%, but very small sample size. To conclude, there's excellent concordance here. There's potential for prediction. My additional thoughts are, well, we're looking at this in the context of neotrip. We now have an FDA indication for pembrolizumab. I think it would be highly relevant to look at that particular trial or other trials that look at pembrolizumab and other IO agents. And then secondly, the gesture of comparing different genomic signatures. We've already seen at least one other signature, the chemokine 12 score, with promise. So I think in the future, we should be mindful that different signatures may have different capabilities of predicting, and we shouldn't be looking at them in silos. The third is another RNA expression study, but a different type of context. This is using a previously described signature, the PAM50 HER2 enrichment score, to pre-select patients for treatment with pembrolizumab. And this is in the context of HER2-positive disease to spare chemotherapy. The background is that there have been studies conducted looking at dual anti-HER2 in the neoadjuvant setting with very respectable response rates, 34% path-CR without chemotherapy. This was the WSG ADAPT trial. That being said, the addition of chemo did confer a dramatically higher path-CR rate in that study as well in a separate cohort. So the question here is, could we use the genomic PAM50 signature to enrich for responses? And this is on the basis of meta-analyses that show that potentially this is a way to predict for response to dual HER2 therapy with an odds ratio of 3.5 described. And then there's a second aspect of this trial. The trial actually aims to harness the immune benefit that could be achieved through the combination of anti-PD-1 plus anti-HER2. And here on the right, you see a preclinical model by Stagg et al. That has been cited often to show the potential synergy of these different drugs. So here's the question: could we use genomic HER2 enrichment to find patients who can forego chemo? And on the right, we see the trial design. This was a single-arm Simon two-stage design evaluating trastuzumab, pertuzumab, and pembrolizumab. They compared this to the WSG ADAPT historical control of a roughly 40% path-CR rate, and they aimed to improve upon that to 60% with their strategy. Here's the characteristics of the patients. I wanted to point out probably the most salient point here is that it's similar to the WSG ADAPT. If you look at the distribution of T-scores, they're quite similar, as well as nodal status. And about 55% of these patients who were HER2 positive by conventional measures were enriched using the PAM50. And here's the results. Meaningful results. The path-CR rate, as you can see here, 46% by central review, but didn't quite achieve the intended 60% alternative hypothesis. On the right, we see exploratory analyses. This has been previously reported that perhaps hormone receptor negatives may respond better to such a strategy, and here we see, in fact, that was true in this data set. And then we also see enrichment of TILs in the patients with high pathologic complete response. So to conclude, this is a meaningful result. I think the path-CR rates are respectable, although not what the authors intended to show. The treatment was safe. So my additional thoughts here are we shouldn't give up on the combination strategy of PD-1, PD-L1 with anti-HER2. I think there's still merit. I think we still need to study it more, and there's a number of ongoing studies. But we don't have a defined role for anti-PD-1 in this setting yet. And then secondly, what about the immune story? So I think the HER2 enrichment signature makes a lot of sense for the dual anti-HER2, but I don't think it adequately respects the second part of the treatment, which was the pembro. So I think in the future we have to really amalgamate different types of genomic strategies somehow in order to achieve the best outcomes. Putting those three together, and then one last poster. So we've learned that HER2 enrichment genomic signature could enrich for response to dual anti-HER2, but we still have an undefined role of adding pembrolizumab in this context. But then we also see a variety of promising genomic IO biomarkers that are emerging. Both the chemokine 12 score and the 27 gene IO score look very promising. So in the starred area are my kind of punchline take-home messages. We've made a lot of progress. I think we need to put our forces together. We should not be doing genomic assessments in silos. We need to really harness the fact that we can collect these data one day. And there is the concept of an ensemble gene set, which is where you amalgamate different genomic signatures that have different virtues to create one that may be perhaps even more predictive. So one last poster. This is also RNA expression data, but used to evaluate the interaction effect of chemo, the tumor, and the immune system. So this is a really important question here that's been described time and time again across the past few days at this meeting. What is the best chemotherapy backbone? So this is a very timely study. And the authors are comparing anthracycline-based neoadjuvant therapy. This is a PARC data set of 22 patients. And then the neotrip study, they used the control arm to look at nab-paclitaxel and carbo. And they looked at 82 pre-selected immune and cell proliferation signatures, and they compared anthracycline versus the taxane. And this is the result. A lot of data to distill in one slide, but I want you to let your eyes make the conclusions yourself. Look at the two columns. It's not a trick question. These look pretty similar, and that's what the authors concluded as well. So the red is upregulated gene signatures, and if you look at that, that's where most of the immune signatures were. And if you want to make a claim about differences, you would state that the AC arm on the left is a little bit darker, meaning that there's a more dramatic increase in those gene signatures. On the flip side, the cell proliferation markers clustered more in the bottom in blue, and there was a more profound downregulation of those proliferation markers with the taxane. So it seems as though the authors and this data are suggesting that there's different roles for the different chemos. Here's a deeper dive. The authors wanted to evaluate a hypothesis, which I think is very important, as to whether the baseline levels would make a difference. So for each of these gene sets, they divided the group into high versus low at baseline, and then they looked at the effect. And what this showed is that, generally speaking, the AC was more likely and more dramatically increasing the immune signatures in the tumors that had low baseline immune signature. And on the flip side, the taxane was more likely to downregulate those highly proliferative tumors. And then one last piece of data. What about dynamic expression of PD-L1, another timely topic? And here we can see both chemo regimens upregulated genomic PD-L1. When you looked at the patients with the low PD-L1 at baseline, there was a more profound upregulation with the AC. Conclusions, both regimens are immunomodulatory, quite similar effect, at least qualitatively, but the AC perhaps had more robust immune stimulation, but the taxane perhaps had a more robust downregulation of cell proliferation. My additional thoughts here are, I think this is a wonderful generalized message, but perhaps we might be oversimplifying. One element to think about is not just the 2-week acute effects of chemo, but what about the chronic or subacute effects of chemo, the immunosuppression of chemo that we're all too familiar with. So on the right, I put a small snapshot of a data set that one of my fellows, Bree Chun, has recently demonstrated at SITC this year and publishing soon. It shows the effect of dose-dense AC on peripheral lymphocytes. Across the board, you see depletion over time. So I think this serves as an expose of the duality of chemotherapy. It could be immune stimulatory, but we also see suppressive effects. And then one other homage to that is looking at the signatures in the anthracycline arm. All the T cells went up, including the Tregs and other suppressive signatures. So I think there's more to the story here. And my clinical take-home message for that is, with competing biologic effects of chemo, I really do think and believe that a clinical trial is needed to answer this question. So thank you to the co-authors for their wonderful work, and thanks for the opportunity to present these data.
Great. Thank you.